Hello, my name is Dr. Luke Schneider, and I've been working at the Anxiety Treatment and Research Clinic at St. Joseph's Healthcare, developing the diagnostic assessment and research tool, and also helping to validate this instrument. Today, what I'm going to do is talk a little bit about the development of the DART and some of the notable features. Specifically, I'll be covering the history and the features of the DART, the overall structure of the DART, and also some specific components that are worthwhile to note. So when it comes to the features of the DART, work started approximately several years ago at the Anxiety Treatment and Research Clinic at St. Joseph's Healthcare in Hamilton, Ontario, Canada. And here at the clinic, the team decided that the DART would be worthwhile to develop because we needed something comprehensive and concise for conducting assessments, something that would be scalable, so would have a modular design, something that would be accessible, for example, no fees for use and easily able to be disseminated, and also a tool that would be suitable for use in both clinical and research settings. So with these goals in mind, the diagnostic assessment and research tool was created. A quick note on who should use the DART. The DART itself is intended to be used by trained professionals. In other words, people that are familiar with diagnostic interviewing, people who have a sound understanding of mental health classification and the system used by the Diagnostic and Statistical Manual for Mental Disorders. And this recommendation not only applies to users of the DART in clinical settings, but this is also a recommendation for research settings and research purposes as well. If we look at the DART, we can separate the DART into three main components. We have a set of preliminary modules that start off the use of the DART and the assessment modules themselves, which comprise the bulk of the DART. And then we also have some concluding modules as well. And I'll go through those in their own section. When we look at the preliminary modules, the first thing that has been developed was a DART screener. This is a 26-item screener and corresponding key, and each item maps onto a DSM-5 disorder. Respondents are given this screener to complete. It's not completed by the clinician or the researcher. And it's a simple yes-no format. So this is intended to be given to the respondent prior to any sort of assessment. And specifically, the purpose of the DART screener is to help with the clinicians and the researchers to identify DART modules to administer. We also have a corresponding DART screener key, which can also be used to identify the modules to be administered. And I have a couple of screenshots here, which I'd like to share. This is what the DART screener looks like. As you can see, there are simple yes-no questions or yes-no responses corresponding to several different questions. When the clinician or the researcher wants to review these responses, they can use the DART screener key. And the DART screener key has several recommendations about which module to complete if a person has endorsed any of the items of the DART screener. We also have the assessment modules. This is what comprises the bulk of the DART. To begin, there is a DART profile document, which is designed to gather background information and also establish rapport with any of your respondents. The assessment modules themselves are quite broad and cover a wide range of disorders. And as mentioned previously, the DART has been developed with a modular design in mind, such that clinicians and researchers can choose modules relevant to the specific population or study. We also have modules that include disorder-specific specifiers, and I'll provide some examples now. This is what the DART profile looks like. So as you can imagine, we have some background information here, and we have information to gather about the presenting problem, general information about the mood, and also other questions to get background information that's relevant to the assessment, like if a person has been given a previous mental health diagnosis. This is a short table of the different modules that are available in the current version of the DART. We covered the preliminary modules by looking at the DART screener and the key. We just saw the DART profile as well. The other modules are disorder specific, and several modules will fall under the umbrella of certain types of diagnostic classifications. For example, we have a module on depressive disorders, bipolar and related disorders, things like several anxiety disorders, obsessive compulsive and related disorders, trauma and stressor related disorders, substance and related addictive disorders, and other things like feeding and eating disorders, dissociative disorders, a schizophrenia spectrum and psychotic disorders screen, and also modules about risk, and also some concluding modules. When it comes to completing the assessment modules themselves, there are several formatting conventions that we use in the DART, and they're used throughout all of the different modules, which I'll briefly review here. In the DART modules, each item is sequentially numbered using an alphanumeric format. And these items should be read in the order in which they're presented, unless otherwise specified. When it comes time to look at some of the other things in the DART, we have other formatting conventions that are present. For example, we have lowercase bold text. And whenever you see lowercase bold text in the DART, that should indicate that the text itself should be read aloud as it is written. We also have text that is in lowercase regular font. And what this indicates is that there are several optional follow-up queries that can or may not be administered by the clinician or the researcher. These are optional to administer to the respondent. Typically at the beginning of each module, but also throughout in other sections, we have completely uppercase text. And whenever a person sees uppercase text, this should signal to them that the information itself is designed to guide the interviewer. So in other words, this is text that should not be read to the respondent. And then finally, we also have gray shaded areas that appear in the DART modules. And the gray shaded area indicates clinical impressions. So it's a place for the clinician to indicate their clinical impressions for the disorder that has been assessed. To give you a better idea of what this might look like in practice, here is a screenshot of the panic attack specifier and panic disorder module of the DART. And as you can see, there are several formatting conventions, which I will briefly review now. You will see on the right-hand side, there is a S, and a P response option. We can also see in the beginning of this module, there is uppercase text intended to guide the interviewer. We also have the bold items, which are intended to be read aloud as written. And then we also have the optional follow-up queries. Regarding the A, S, and the P response options, I'll briefly review them now. When it comes to the A response option is intended to be used when the symptom or the diagnosis is absent, or if the item is negatively endorsed. On the other hand, we have the P response option, which denotes that the item has been positively endorsed or that a diagnostic threshold has been met. Here's an example of what that might look like in practice. For example, item number 6 asks if a respondent has had more than one panic attack. If they say yes, they have had more than one panic attack, then the correct response to circle would be P, because the item has been positively endorsed and that item is present. On the other hand, if a person says no, they haven't had more than one panic attack, then the correct option to indicate would be A, because that specific item is absent. And of note, you might see that little X box below the A. Whenever you circle an A response option and there's a X box below it, that is a stop box, and that should indicate that there is no reason to administer any of the more items in the module, because this specific item that was assessed is germane or very important to the diagnosis of the disorder that is being assessed. Of course, if you have clinical or research reasons to continue on administering the other items, you can do so. But typically for assessment purposes, if you see that stop box, you can stop administering that module and move on. If we look at item number 7, there are several items that we are asking a participant about, whether or not they've had more panic attacks or they're worried about having these panic attacks. For example, if any of their behavior has changed because of the panic attacks. And here we see the uppercase convention used yet again to indicate that at least one item in number 7 has been checked. And so again, if a person has one or more item that has been endorsed, the correct response would be P, because the item is present or that threshold has been met. On the other hand, if that isn't the case, then the absent or the A option would be checked. We also have other conventions here. For example, item number 8 asks if the items are not better accounted for by substance. And so if that's true, that the symptoms are not better accounted for by a substance or a medical condition, then the correct option to select here would be P, because that's true. The symptoms are not better accounted for by a substance or a medical condition. On the other hand, if you have good reason to suspect that a medical condition may be highly related to these symptoms, then the correct option to select here would be A, because it is false. The symptoms are better accounted for by a substance or a medical condition. We also have a similar formatting convention used in item number 9 of this module, asking if the symptoms are better accounted for by another mental disorder. If we think that it isn't, then we would select B, because it's true that the symptoms are not better accounted for by another mental disorder. On the other hand, if we have good reason to believe that it may be, then we would select A, because this statement here is false. The items are better accounted for by another mental disorder. Now, the final thing to mention about these response options, which I haven't covered so far, is the S category. And so the S category itself is used to denote symptoms that are subthreshold. So the symptoms may be present, but below clinically significant levels or below a diagnostic threshold. To give you an example of what that might look like in clinical or research practice, a participant may endorse limited clinical distress. For example, they might say they used to struggle with these symptoms before, but they have a handle on it now. So it might not be appropriate to choose A or absent because those symptoms are still present, but it also wouldn't be correct to endorse that item if the person has control over it. So this would be a good indication that the subthreshold response might be appropriate. Another example is if a patient or respondent indicates that their symptoms are below the threshold for things like frequency or severity that's being assessed. And sometimes we will hear respondents say things like, sometimes my worry gets the best of me, but more often than not, I can control it. That would be a good indication that the subthreshold response can be used. And I'll provide more information on the S or subthreshold option a little bit later on in this discussion. So to review, we have the A indication, which should be used when the symptom or diagnosis is absent or the item is negatively endorsed. We have the S or the subthreshold response option, which should be used when there are some symptoms that are present, but they're below the clinically significant level or they're below the diagnostic threshold. And then finally, we have the P or the present option, which should be selected when the item is positively endorsed or a diagnostic threshold has been met. And to review again, whenever you see the stop box, you can safely end that module and move on. Now, in addition to the formatting conventions and the modules that I just reviewed, we also have some different or unique modules that function a little bit differently. For example, in the DART, there is a risk assessment module, and there's no diagnosis that is given when this module is completed. The intent of this module is to assess for the presence of suicide, self-harm, and homicide risk. We also have a depressive disorder specifiers and bipolar disorder specifiers module, which are standalone modules that can be used to supplement other modules. For example, if you're assessing for depression and you want to do a more thorough evaluation of whether or not other disorder specifiers are present. Those standalone modules can be a helpful supplement to the other modules of the DART. And then finally, in the depressive disorders module at the very end, there is something that's called a mood map. And the mood map itself is a blank graph that can be used to graphically represent whether the level of depression that a person is experiencing over time. This can be particularly helpful when you're assessing things like the presence of persistent depressive disorder. And I'll show a screenshot of that in just a moment. First, here's the self-harm behavior in the risk section of the module. So as you can see, there's items there assessing self-harm behavior, either current or past. And then in the gray area, instead of diagnostic or clinical impressions, there's a summary of what you might see. And later on in this module, or when you complete this, the self-harm module, there will be a section at the end to do things like suggest a safety plan or other types of things that you might need to do to keep your respondent safe should some of these items be endorsed. This is what the additional depressive disorders specifiers module looks like. And again, this is a helpful supplement to the existing depressive disorders module itself. And it asks for things like assessing for depression with anxious distress or with mixed features. And finally, here we have the mood map. Again, a very simple graph that can be used with your respondent in the session to graphically depict what their level of mood has been like and how that has changed over time. Again, this can be very helpful when assessing for the presence of a major depressive episode, particularly when that's also co-occurring with persistent depressive disorder. Now we talk about the concluding modules. So we talked about the introductory modules, the main assessment modules, but we also have some concluding modules. For example, we have a module that is called behavioral observations. And this module can be very helpful, especially in clinical practice, because it has a checklist of appearance and affect and other types of descriptive information that can be very helpful when writing a clinical report. There's also blank space for additional notes. And finally, we have a DART summary. And this DART summary is intended to summarize some of the information with the respondent, ask about things like goals for change, if that's relevant to why you're using the DART. There's also a spot to record your diagnostic impressions overall, and also a spot to talk about and record treatment recommendations, again, if that's relevant to why you're using the DART. This is what the behavioral observations module looks like. So you can see a checklist that can be very helpful when writing clinical reports. And this is what the DART summary looks like. Again, sort of some information there to ask the person, now that you're finished doing the DART modules, is there anything else that they would like you to know, asking about goals for treatment, and also a spot for diagnosis and relevant personality features. So that's the DART in a nutshell. Now I'd like to share some clinical tips that have been shared with our clinic based on users of the DART over the last several years. The first tip that is often reported to us is that we should really familiarize ourselves with the modules. So comfort with and proficiency in administering these DART modules will increase with practice. And the more that you practice using the DART, the easier that it will become, especially because we've made gone to great pains to make sure that the formatting conventions are consistent throughout and the language is clear and concise. Also, get comfortable with using the mood map. Again, that can be very helpful in tricky diagnostic situations when there's a complicated presence of depression. And don't forget that behavioral observations module. Again, this can be very handy when writing assessment reports. And also remember the specifier section when giving a diagnosis. So at the end of some of the DART modules in the clinical impressions section, not only will you be determining whether or not a person meets a threshold for a certain disorder, but below that, there will also be specifiers that may be important to ask about and consider when giving a diagnosis. And the S response, the subthreshold response, also does warrant serious consideration. Respondents' symptoms will often fall in a gray area and will need to be disentangled. A lot of the DART items are not dichotomous. It's not yes or it's not no, because there's sometimes a sometimes option. And a large number of subthreshold responses, if you find that you're going through a module and you're giving a lot of those subthreshold responses, could indicate the consideration of a not otherwise specified diagnostic category. And when something like this happens, it may be a useful indication that when you're doing the assessment with the respondent, you may need to consider the function of the endorsed symptoms to arrive at the most appropriate diagnosis. Now, even though the DART is modular in nature, we really encourage users to consider the whole picture. Many modules will ask you to consider whether the symptoms are better accountable by another mental disorder. And this is a question that we would expect people to keep in their mind at all times while doing the DART. So asking follow-up questions may help clear up the clinical picture, and it's okay to go back to a previously administered module. For example, people aren't modular in nature, and sometimes you will get clinical information in a subsequent DART module that is actually relevant to a module that you already assessed. In that sense, it's okay to go back to a previously administered module. And disorder-specific information is often reported asynchronously by patients and respondents. So case conceptualization is recommended to be an ongoing process as you're administering the DART. And with that in mind, it's okay to ask follow-up questions as necessary. For example, it's okay to write outside of the notes box. We have in many of the modules a box to write notes, but it's okay to scribble on other parts of the page, especially if you find that helpful for you to complete the DART. To end this presentation, I'll talk a bit about accessing the DART. The DART itself was designed as an open access tool. And at this point in time, the open access tool can be attained presently by contacting Dr. Randy McCabe at the following email. Future versions of the DART may be accessible through McMaster University and their Industry Liaison Office upon request, and that link will be coming soon. But if anyone is interested about more general information about the DART, that information is available on the McMaster website at the following link. Thank you very much.